Our afternoon session is about nutritional interventions for geriatric syndrome, which reminds me one of the famous line that you are only as old as you feel. One of the famous line is about you are only as old as you feel. So if you feel like you are 21 or 25, like female usually do, fantastic. But if you feel like you are 80s or 90s on Blue Monday or on Friday afternoon, like now, don't worry. Our following speakers are ready to provide some tips that address the nutrition that can just change that. So let's welcome Professor Hindanoli Alai, who is the president of National Center for Geriatrics and Gerontology in Japan, and Professor Huang Qingzhen, who is the professor emeritus at the Department of Biochemical Science and Technology at National Taiwan University, to chair the following session. Let's welcome Professor Alai and Professor Huang.
Thank you for the introduction. Good afternoon, everyone. I hope you enjoyed the lunch, healthy lunch box today. Okay, let's work. I'd like to welcome the session 1, which is nutrition intervention and for geriatric syndrome. I'd like to chair this session with Professor Xinjiang Wan from National Taiwan University. We have 3 excellent speakers from Singapore, Thailand, and Taiwan. And each speaker will make a presentation for 30 minutes, followed by 20 minutes discussion. So I'll chair the first and third speaker, and Professor Huang will chair the second speaker. So I'd like to invite the first speaker, Professor Shiong Lim from Singapore. He is the director of Institute of Geriatrics and Active Aging, Tock Seng in Hospital, Singapore. The title of his talk is Nutritional Intervention for the Prevention and Management of Sarcopenic Obesity, an Evidence-Based Approach. So let's welcome Shiong.
Yep, so it's a privilege to be back here again. I was here last year, and this year, again, very grateful, very overwhelmed by the hospitality. And I hope that I'll be able to energize you after lunch with a talk that's close to my heart about sarcopenic obesity. We're looking at the nutritional interventions for its prevention and management. For the purpose of this talk, I do not have any financial disclosures of note. So we'll start off first with a picture of 2 gentlemen. They appear to be similar externally, same BMI, but are they equally healthy? So really what we have to do is to peel beneath the skin to look at their body composition. And as you can see, the gentleman on the left, he has decreased lean mass, muscle mass, and also increased fat mass. And already that is the body composition that is pathognomonic of sarcopenic obesity. So what is sarcopenic obesity? Well, this refers to the confluence of 2 public health crises, namely the obesity epidemic and population aging. And together, they give rise to the double whammy of sarcopenic obesity, what some term the hazardous duet. So it's like that waterfall that you see. With one, it can cause an effect. And when the 2 come together, it's almost like going downstream with a synergistic downstream deleterious consequences. So the prevalence of SO ranges from about 1 to 30%. So therefore in sarcopenia, we need to think about it in terms of its 2 phenotypes. Sarcopenia, that is non-obese, and secondly, the fat-free or sarcopenic obesity. The reason why this is important is because in sarcopenic obesity, besides the decrease in muscle mass and strength, there is also the increase in fat mass, which is both inter- and intramuscular. In terms of pathogenesis, this arises because of the aberrant muscle-fat crosstalk at 3 levels. A systemic dysregulation resulting in cytokines affecting both muscle and bone. Bone dysregulation releasing the osteokines. Fat dysregulation releasing adipokines affecting the muscle. And lastly, muscle dysregulation releasing myokines affecting the fat. So at that level, causing that very complex maze that we see. This then gives rise to the meta-Beijing cycle, whereby fat, which is redistributed, becomes such that there is ectopic infiltration of the muscle, what we call myosteatosis. This then gives rise to mitochondrial dysfunction, lipotoxicity, the release of reactive oxygen species, which then leads to the downstream consequences. The downstream consequences can be conceptualized as an obesity domino effect. Starting first with increased obesity, it then can lead to increased systemic inflammation, mitochondrial dysfunction, vascular damage, and increased reactive oxygen species, such that obesity then gives rise to a premature aging phenotype with compounding effects, causing metabolic and cardiovascular side effects. It can also give rise to geriatric syndromes as well as frailty. This slide shows data from the Geriatrics study in Singapore, and we basically compared 4 body phenotypes: the normal, obese only, sarcopenia, and sarcopenic obesity. And what we found was that the SO group had the highest levels of monocyte chemoattractant protein 1, or MCP1, which is a marker of adipose tissue inflammation. Interestingly, there was no difference in CRP, TNF-alpha, and interleukin-6, which are general markers of inflammation. And what this shows is that perhaps adipose tissue inflammation, which is localized, is an early event and therefore potential biomarker of sarcopenic obesity. In the Geriatrics study, we also demonstrated that intermuscular adipose tissue was increased in SO. So as you can see, when we compare the 4 phenotypes using MRI imaging of the thigh, the IMAT was highest in the SO group. And this was associated with raised MCP1 as well as decreased performance as measured by SPPB. So if you were to look at the images, so let me orientate. Blue would be the muscle, green is the subcutaneous fat, and red is the intermuscular fat. In obesity, we see a lot of increased green, which is the subcu fat, a little bit of red, that's muscle fat in the muscle. But in sarcopenic obesity, what you then see really is that the muscle decreases, and there's a lot of red intermuscular tissue. And some of you are smiling, that's right. The next time when you have your delicious beef, the Kobe beef, right, with the juicy fat, think of IMAT, think of sarcopenic obesity, because that's what's happening in our body when there is sarcopenic obesity. So the clinical consequences are multifold and systemic. There is metabolic, cardiovascular. It can also give rise to lung problems, typically obstructive sleep apnea, and arthritis, typically osteoarthritis of the knee. This then can give rise to geriatric syndromes such as frailty, osteoporosis, cognitive impairment, depressive symptoms, and dementia. And from the meta-analysis, what we know is that SO is associated with about 1.5-fold increased mortality. It's about 2-fold increase in type 2 diabetes, 4-fold increase in metabolic syndrome, and about 2 to 4-fold increase of geriatric syndromes. So again, data from the Geriatrics study comparing between the 4 body composition phenotypes with obesity defined as waist circumference as an indication of central obesity. We demonstrated the SO group again performed worse in physical performance measured by SPPB and gait speed, and strength measured by hand grip and knee extension. Data from the New Mexico study likewise showing that it is the SO group that over time had the greatest decline in instrumental ADL. So in SO, therefore, we have 2 moving parts, sarcopenia, obesity, and most of the current definitions look at it this way. At the AWGS group, we feel that the definition should look at an integrated way with fat and muscle look at together. That is a work in progress. For now, the leading consensus definition is with the Aspen-ESO group. Algorithm is shown on the left. So if someone has a high clinical suspicion or with a high BMI or waist circumference through screening, this then proceed on to the 2-stage diagnosis. Firstly, impaired muscle function measured by muscle strength, and secondly, altered body composition with increased fat mass percentage and decreased muscle lean mass. If they fulfill the criteria by staging, is to look at the presence of complications, and if yes, there will be stage 2. So taken together, right, I would like to actually share this proposition that we need to think of SO as a potential upstream target for healthy aging to avert midstream complications, cardiovascular, metabolic, respiratory and functional, as well as downstream adverse consequences of falls, functional decline, institutionalization, and even death. And the reason why SO is a window of opportunity is because it represents a systemic metabolic dysregulation. Carla Prado actually shared this conceptual framework of the LC ratio, L being the metabolic load and C being the metabolic capacity, and a high LC load is therefore bad. A load would involve things, the usual bad stuff, such as insulin resistance, inflammation, metabolic dysfunction, and capacity would be an increase in physical, cognitive, and psychological capacity. So what you can see in the upper panel is that over time, the ratio increases, right? The metabolic dysfunction actually decreases, showing that there's a life course increase in LC. But not only that, in the lower panel, you see that the confidence interval narrows. And what this means is that the ability of the body to really respond to LC ratio narrows, such as over time, with age, is more likely to be one of metabolic dysregulation. And this, therefore, sets the case for lifestyle intervention across the life course. And basically, there are two scenarios. The first is a normal one, and I think applies to some of us here in the audience, right? From a normal weight, we kind of gain weight over time, be it a sedentary lifestyle or the diet. And usually the weight tends to appear in the tummy. And I know in Chinese culture, right, the Tao Ge, right, the central fat is supposed to be prosperous. But from a health point of view, it's actually not very healthy. So the first scenario is that of weight gain. The second scenario, which is less common, is actually that of weight loss. Someone coming from a point of morbid obesity and losing weight to become SO. And what distinguishes between sarcopenic obesity and obesity is the allostatic response. So in a normal response, in response to stress, it goes up and comes down. In obesity, in the middle panel, it is impaired. It goes up, comes down a little bit. But in sarcopenic obesity, there are two possible patterns. One of inadequate response, or secondly, of an prolonged response. So therefore, when you start to think of the factors for sarcopenic obesity, be it factors associated with aging or disease factors, acute or chronic, a typical pattern emerges, right? In blue, it will be the physical activity. In red, the nutrition, and green, inflammation. And therefore, the case for nutrition and exercise, which is currently the mainstay of treatment in sarcopenic obesity. For nutrition, it will be watching the calories, increasing protein, and in exercise, both resistance and aerobic exercise plays a role. How about pharmacological agents? There are some promising ones, such as GLP-1 agonists, hormone replacement therapies such as testosterone, SARMs, and aminoretin, which is the ghrelin agonist, as well as anti-myostatin treatments. But of note, there are no definite studies in sarcopenic obesity. While they may show some benefit in body composition, the benefits on muscle function is inconsistent. And very importantly, even though they may be successful in reducing fat mass, there's also loss of muscle mass as well. So for instance, in the STEP 1 study, semaglutide, which is a GLP-1 agonist, actually led to fairly marked 58% decrease in lean mass, which exceeds the 25% threshold as defined by the quarter fat-free mass rule. Bariatric surgery, again, has a role in morbid obesity. It is successful in reducing breast tissue, but again, it can lead to profound muscle loss. So these needs to be taken in tandem with resistance exercise. And data suggests that the sleeve gastrectomy technique possibly preserves muscle mass better than the very usual rule on Y bypass technique. So let's talk a little bit more. And I know this is a nutrition talk, but nutrition and exercise are really like brothers and sisters in sarcopenic obesity. So I'll be talking about the brother before I go on to the sister. So exercise. Resistance exercise is effective in reducing body fat and improving muscle function. And combining both is with aerobic and resistance is actually more effective than either form alone. Recommendations from the American College of Sports Medicine, a minimum of 2 non-consecutive days each week with both slow and fast velocity components, aiming for 1 to 2 sets, 8 to 12 repetitions, 60 to 65, 1 repetition maximum, and going up slowly to 75 to 80% RPM. And usually we start slow to moderate, in terms of intensity, duration, and frequency for various reasons. Firstly, to minimize the risk of injury. Second, to facilitate adaptation. And this, on the whole, would then improve adherence. A quick word about electromyostimulation. And whole body electromyostimulation has been studied in the context of SO. This is basically an exercise mimetic approach which delivers a mild electrical pulse to targeted muscle groups over a period of time. Results show that it can improve body composition and muscle function, but effect sizes are small and may not be effective in more severe SO. It is generally safe if properly applied and supervised, but take note that in certain cases, especially if it's not properly done, it can lead to side effects such as rhabdomyolysis. So this is a company in Singapore, Quantum TX, which has developed EMS technology that just focuses on delivering the stimulation to one thigh, one leg only, instead of the whole body. And they have marketed it as a mitochondrial stimulation therapy given over 3 months. Initial results are promising, but I think more studies need to be done, especially in the context of SO, to determine really it is effective. Finally, let's get on to nutrition. And the core hallmarks and components would be caloric restriction and protein supplementation. And in caloric restriction, basically we are looking for moderate decrease of about 500 kilocalories per day, giving rise to 0.5 kg per week, aiming for 8 to 10% weight loss at 6 months, followed by maintenance. It is not easy, and oftentimes compliance is an issue. In terms of protein supplementation, aiming for 1 to 1.2 grams per kg per day of protein divided over the 3 meals. We'll first review the data of nutrition and or exercise, right? Earlier I said brother and sister. Are they really brother or sister? Brother and sisters. So one of the key studies was by Dennis Villarreal, published in 2011. And what this study did was a 1-year RCT of older adults with obesity, comparing between diet, exercise, and combination. As can be seen on the graphs on the left, combination diet exercise provides greater benefit in physical function than either intervention alone. But very importantly, the diet group and the combination group both had weight loss, about 10%, 9%. But the difference was that if you had combination, you had less lean mass and BMD decrease, right? So this actually supports the role of combination as opposed to just diet therapy alone. Another way of thinking about it is to look at protein synthesis. So even in older people, if you have a high enough protein intake, you can overcome the anabolic threshold for protein synthesis. But when you've exercised, the benefits is twofold. So it is not about exercise or nutrition, but rather exercise and nutrition. And I like it the way it's put. Exercise is king, nutrition is queen. Put them together, you've got a kingdom. The next study again comes from the group of Dennis Villarreal, and it seeks to answer the question of the types of exercise. So in this RCT, they look at aerobic, resistance, and combination in a weight management program. And the results are again very interesting. So in the control group, if you look at panel 3, they actually preserve their lean mass, but guess what? They perform the worst in terms of physical function and strength, despite the preserved mass. And it is really the combination group that you had the best physical function. Thus, weight loss coupled with both aerobic and resistance activities was the most effective in improving physical function in obese older persons. Let us take a deeper look into some nutritional interventions. So in the hypocaloric diets, they are effective in reducing adipose tissue, but very importantly, they may lead to muscle loss and may affect micronutrients as well as BMD, especially in those with pre-existing sarcopenia. So the key is really a modest reduction in energy intake and moderate weight loss amounting to about 0.5 kg per week, and at 6 months, about 8 to 10% of the initial body weight. Part of the mechanism may also be due to the satiety effect from the protein intake in the moderate energy restricted diet. Some people has been a fad about very low caloric diets in the younger people, also known as crash diets or semi-starvation diets. used for rapid weight loss. And typically what is done is that you restrict the calories and you replace it by the high proteins, or in the case of ketogenic diet, high fats, and also increase the water intake. However, caution needs to be borne in mind. Firstly, the long-term feasibility is debatable because of concerns about nutrient deficiencies, the emergence of disturbed eating behaviors, and also there is muscle loss even though there's adequate protein intake. Very importantly, the benefits are not sustained. When one transitions off the diet, what happens is that individuals gain weight, and this weight is in the form of fat rather than muscle. So based on the available evidence, we do not recommend very low caloric diets in older persons. People also look at intermittent fasting, and one of the patterns that shows promise is time-restricted eating. And basically what this does is to have a similar intake of food consumed within a restricted time, typically 6 to 10 hours. So instead of eating ad libitum throughout the whole day, is limited. So in early TRE, for example, you may start at about 8 o'clock and you end off about 6 p.m. In late, you may start earlier, 10 o'clock or so, ending about 8 p.m. So the idea is that you limit the time that you eat. What do the results show? Actually, there's fairly good compliance to time-restricted eating. So you can see in the panel, 12 p.m. to 6 p.m., most people can adhere to that, right? And the duration of eating is less. And what it basically does is that it reduces the hunger and the desire to eat, especially dinner, right? So I think for those who have a huge dinner and dinner is your problem, this may be one approach to think about in older persons, although more studies need to be done. A word about protein intake. And really the important thing to keep in mind is that in older persons, because of the phenomena of anabolic resistance, we need to have a higher protein intake of 1 to 1.2 grams per kg body weight, as recommended by the Putaj group, which is higher than the 0.8 grams per kg per day body weight recommended by RDA. Essential amino acids may also be helpful, for example, leucine about 2 to 2.5 grams. And very importantly, this needs to be spread out throughout the 3 meals because intake exceeding 30 grams are not incorporated inside. So let me illustrate, right? So on the left is the typical pattern, I think, of many younger people, like breakfast or no breakfast, a moderate lunch and a very heavy dinner, right? So if 30 grams is the threshold, right, then what you have is 10 plus 15 plus 30, only 55 grams of protein is synthesized. In contrast, if you spread out over 3 meals, you then have the maximum benefit of 90 grams. And I think for older adults, even, I think the weakness is breakfast. So the challenge is to ensure that during breakfast, in the meal of breakfast, there is proteins going in so that it's spread out over the 3 meals. Other issues identified in literature also include other nutrients such as omega-3, carotenoids, selenium, vitamin D and E and C, and isoflavones through different mechanisms. However, the evidence for these treatments is still inconclusive and sometimes conflicting because of limited studies and also the small sample sizes. Dietary patterns, diet quality also have shown promising results such as tea, the DASH diet, vegetarian dietary pattern, Mediterranean diet. But again, evidence limited to observation studies, including cross-sectional ones, where reverse causality cannot be excluded. And the follow-up period typically is short, and there's a lack of standardized criteria for ASO. So again, I think more studies, especially RCTs, need to be done if we really want to understand their role. And lastly, this debate about animal versus plant proteins. Some studies suggesting animal-based protein may have a more pronounced anabolic effect, but important to keep in mind that this may also be due to the study quality with differences in type and quantity of essential amino acids. Hence, at this juncture, that precludes definitive conclusions. And finally, a word about technology. Right? Technology definitely has a role. This is a study that we conducted in Singapore looking at multi-component intervention in frailty prevention. And so basically there is an assessment followed by recommendations instead of polypharmacy, nutritional recommendations, and exercise. So the exercise has 2, Tai Chi as well as cycling, which is resistance and balance. And in the nutritional panel, through pictures, the AI is able then to kind of tell the person about analysis of the food groups and the recommendations about, for example, they're not taking the proteins, recommend you should take more proteins. And the results are promising in this pilot study with benefits in terms of decreased frailty, incidents, SPPB and hand grip strength. There was enjoyment. Although in terms of the usability, some issues were surfaced about technology usage in older persons, but generally the usability is of a reasonable score. How about future research? Well, there are many gaps, more questions than answers. I think that's a good thing. It means that all of us in this room, there's potential for us to look deeper into this area. This includes the optimal source and dose of protein intake, safe and sustainable strategies for caloric restrictions. I mentioned about time-restricted feeding. Sex differences possibly as well in the response. So this very interesting study showing that protein intake in women in the nurses' health study actually reduces the risk of frailty. And last but not least, right, compliance is really like that thing that all of us are really looking at, right? What can improve compliance, that holy grail that needs to be answered? So social, cultural, and behavioral factors, technology maybe as enablers to promote adherence in the real-world implementation. So in summary, I presented the case that sarcopenia could be a potential upstream target to avert adverse outcomes. This is due to the obesity domino effect. Remember, exercise is king, nutrition is queen. Put them together, you've got a kingdom. For exercise, it is resistance and aerobic. And for nutrition, protein intake that is adequate, spread out over 3 meals with reduced caloric intake. A word of caution about caloric intake, if you are reducing it, is that this needs to be coupled with resist exercise, preferably supervised to ensure there's adequate protein intake and nutritional counseling. For the research at Geriatrics, I'm very honored to have a community to make it possible in terms of the funders, the adult participants, our community partners, and last but not least, the team, without which it would not be possible. So thank you very much.
Thank you, Shiong, for your excellent talk on sarcopenic obesity. So I'd like to ask Professor Huang to chair the second speaker.
Thank you, Professor, because we have a discussion session after all 3 talks.